All right, so I see I've got a challenge in store for me because I have to convince you that the answer was yes to the last question. And one of the frustrations I've had in my life as a physician is that we really haven't made progress in the treatment of acute myeloid leukemia in the elderly, at least with standard therapy. And unlike the spectacular results you just saw with promyelocytic leukemia, there really has not been any improvement in our treatment of elderly patients with other forms of acute myeloid leukemia in my almost 40 years as a physician since medical school. And but one exception to that is the use of allogeneic stem cell transplant, and I'm going to show you evidence for that here in a moment. So when allogeneic transplants were initially developed back in the 1960s and 70s, the initial concept was if we could just give enough radiation to patients or high-dose chemotherapy, we could kill every last leukemia cell. We know it would also kill the normal cells in the bone marrow, but we could give our bone marrow transplant and restore hematopoiesis, and that would be a way that we could give enough chemotherapy that we could cure patients. And obviously, when we do this in practice, this is a fairly toxic treatment, and it's one that you can't do to older patients because they just can't tolerate that theory or that therapy. And the goal of the conditioning regimen in this concept was give enough chemotherapy or radiation to eradicate the malignancy. It would also provide enough immune suppression to prevent rejection of the transplant and create space for the graft to take and grow. And as you all appreciate, the major limitation to this idea is that AML and most leukemias are diseases of older people, and the median age is over the age of 60, and we just can't give that super high-dose therapy to these individuals. But fortunately, much of the benefit that we see with allogeneic transplants is not from the chemotherapy itself. It's the immune effect of the transplant, the graft versus leukemia effect. And so we may not need to give that maximally ablative therapy to get cure of the disease. And in fact, a lower dose, non-myeloablative or reduced intensity regimens are sufficient to prevent rejection of the transplant. And at least in the beginning, we hypothesized that this might be enough to in fact cure patients with acute myeloid leukemia and allow us to treat older patients and those with comorbidities that just couldn't tolerate that ablative treatment. So again, the view of the preparative regimen has sort of evolved over time. The old view was just to give the highest dose of chemotherapy that the patient could stand, to a new view where we try to administer a well-tolerated preparative regimen that would have some cytoreduction of the malignancy, but allow engraftment of the donor cells, prevent rejection of the transplant, but then give those donor T cells a chance to eradicate the disease through the graft versus malignancy effect. So the non-myeloablative preparative regimen is sort of illustrated here. You give your preparative regimen, it doesn't destroy all of the host cells. Some leukemia cells and some normal cells survive, but the donor hematopoietic cells then induce really a graft versus hematopoietic effect. They destroy the recipient normal cells as well as the leukemia and all hematopoietic cells of recipient origin. And then when it works, you end up with donor-derived hematopoiesis and eradication of the disease. And we can do other immune manipulations, including donor lymphocyte infusions, if needed, to try to augment that GVL effect. Well, this has allowed us then to reduce the toxicity of the regimen from the high-dose TBI, total body radiation regimens, and cyclophosphamide, or busulfan cyclophosphamide, to less toxic regimens, such as the fludarabine-containing regimens with lower doses of the alkylating agent, so busulfan or melphalan and fludarabine, and then ultimately even to non-myeloablative regimens where if you gave that regimen and no transplant, you would recover because you haven't destroyed hematopoiesis. So the low-dose TBI regimen, 200 rads or 2 gray of radiation that the Seattle group uses, or even fludarabine and nitroribicin, we used that in our initial studies, and we showed we got engraftment and in fact had some long-term survivors. The non-ablative regimens are less toxic, and they also are sort of less cause less drastic and rapid immune depletion. And so the donor-derived cells can engraft, and the patient has less of a period of time at risk, if you will, for opportunistic infections and other complications. One of the interesting things with the non-ablative regimens is that we actually see less graft-versus-host disease. So what graft-versus-host disease is actually a combination of the immune graft-versus-host reaction on top of the toxicity of the preparative regimen. So when you get chemotherapy or radiation, it damages host tissues. Those tissues produce inflammatory cytokines that then amplify the immune graft-versus-host reaction and produce graft-versus-host disease. Now, if we have less toxic chemotherapy, we have less of those inflammatory cytokines, and then ultimately the severity of graft-versus-host disease that we see is in fact reduced. And this is our own analyses that we did now 10 years ago, where we looked at people getting the truly non-myeloablative regimens and comparing them to ablative chemotherapy. And we did in fact see with the same immunosuppressive therapy that the rate of acute graft-versus-host disease was in fact lower using the non-myeloablative therapy. So if we look at the end results of non-myeloablative transplants, the toxicity is reduced, graft-versus-host disease is reduced. We see about the same kind of infections, but we can generally treat them because the patients are in better general condition. And that results in a lower rate of treatment-related mortality, and it allows us to treat older or medically impaired individuals. So we can try to optimize the chemotherapy to reduce toxicity and try to find the sweet spot, if you will, where we would get the optimal benefit without excessive toxicity. And the use of intravenous busulfan has allowed us to get more reliable drug levels in our patients. I won't take a lot of time to describe that now, but basically the use of IV busulfan provides much more reliable dosing than the oral formulation. So we've developed busulfan and fludarabine as a preparative regimen, and it is significantly less toxic than busulfan and cyclophosphamide, even with the same dose of busulfan. And this was, we showed about 10% treatment-related mortality with this regimen, about 75% survival of people with AML in remission using this regimen. And with this approach, even patients with adverse cytogenetics have about 50% long-term disease-free survival when those patients are rarely cured with standard chemotherapy. So now we come to the issue of older patients, and what can we do to improve their outcome? So back in 2001, we started a study where we took everybody with acute leukemia, and we started with 259 patients. Over the age of 50, and then with the idea that if we could, we were going to do a transplant in first remission for these patients, and then see if they did better than people who couldn't get a transplant. And so there were, again, 259 patients with median age of 65. About half of them had high-risk cytogenetics with -5 or -7. Almost all got an Ara-C-containing induction regimen. And our first hurdle is getting them into a first remission. About 99 got a CR, or 38% of the patients. And in those days, this was an aggressive step because there was no precedent for doing transplants in these older patients. And we actually ultimately did a transplant in 14 of those patients using a melphalan and fludarabine combination. So actually a pretty low dose of melphalan, 100 milligrams per meter squared, which is very well tolerated, and tacrolimus methotrexate prophylaxis. And this is the results of that study. So the yellow line is the 14 patients that got transplant in first remission, and about 60% of them are still alive, at long-term disease-free survivors. And the other lines are people who didn't get a transplant. Either they didn't get a consult because they didn't want to consider the procedure, or we couldn't find a donor for them. And Eli Esty in our group was trying to find some way that we could explain the differences on the basis of patient selection. But as you can see, it's a pretty night and day difference that 60% of the transplant patients survived compared to less than 10% of the people getting other treatment. And you can see that the median survival of the group not getting a transplant was less than 1 year. And on the basis of these findings, actually many groups have now duplicated this work, including the Blood and Marrow Transplant Clinical Trials Network in over 100 patients have somewhere between 40 and 50% long-term disease-free survival. And the CALGB, the Cancer and Leukemia Group B, in their study, found about 40% disease-free survival with hematopoietic transplants, again compared to 20% of patients surviving 2 years receiving standard chemotherapy treatment. So clearly in the older patients, if we can find a matched donor and they're even have a performance status of 80%, are in generally good health, the application of an allogeneic stem cell transplant clearly improves their disease-free survival. Now we hope that we can build upon this. Can we improve this graft versus leukemia effect that is in fact curing these patients who would otherwise relapse from their disease? And so we're trying to focus the immune system on targeting their malignancy. We also don't care if the immune system destroys normal hematopoietic cells, since we're replacing them with the transplant. But we want to avoid reactivity against the visceral tissues of the body and produce graft versus host disease. And so one can try to target cell surface antigens that are specific to the hematopoietic system, either using CAR T cells, as we're doing in lymphoid malignancies, but we're trying to develop those against myeloid targets, or against minor histocompatibility antigens present on myeloid cells. We want to avoid, however, the broadly reactive antigens that might be producing graft versus host disease. One of the interesting ones here is proteinase 3, which is aberrantly expressed in myeloid leukemia cells, and that it's a target for T-cell responses, and that Jeff Mulder in our group is trying to develop vaccines, and in fact now has a monoclonal antibody against PR1, a epitope of proteinase 3, which then can selectively eliminate leukemia cells. So we hope that one can make this approach to treatment even better by targeting the immune reactivity against the leukemia. And then one other opportunity is potentially to use natural killer cells that naturally kill leukemia cells, and in the setting of transplants actually reduce graft versus host disease by ablating host-derived dendritic cells that could stimulate graft versus host disease, and also killing recipient T cells that might reject the transplant. So the addition of NK cells to an allogeneic transplant might fundamentally improve all these aspects, and this is something that we're looking at in prospective trials. So moving forward, we would hope that we can further optimize our non-ablative allogeneic transplant by initially getting the transplant in with minimal toxicity and graft versus host disease, and then ultimately using vaccines, monoclonal antibodies, or immune effector cells to improve the graft versus leukemia effect and ultimately improve the number of long-term survivors. So again, I hope I've convinced you to change your vote and vote for allogeneic transplant next time you get the opportunity. Thank you.
So thank you very much, Dick Champlin. Any questions? Please. No. Sorry. Okay, please.
I know in United States, more and more elderly patients receive the allogeneic transplantation. And I also know Dr. Mohanty Moti used 2-days Busulfan plus 5-days fludarabine and also ATG as conditioning. Do you have experience with this conditioning? And would you like to have comment on the condition and your conditioning?
So that the most common regimens used are either busulfan and fludarabine with or without ATG, or melphalan and fludarabine with or without ATG. But other agents have been used, and I don't have experience with those.
Any questions? So thank you.